Welcome back, everybody. It is my privilege and honor to present Dr. Alberto Sola. He is the president of Universal Ibogaine out of Quintana Roo, Mexico. And this keynote is sure to be incredibly intriguing and curious for all the people that have questions as far as the molecular and scientific properties of Ibogaine. This is definitely where you want to ask them. So Dr. Sola, please take it away, and we're all excited for your talk.
Thank you, everybody that's around. I'm going to talk about our data, the one that we've been collecting since a while now, and what it means. In Universal Ibogaine, we're trying to create the new standard for addiction treatment. That means the detox part of the opiate addiction. We want to reform it to make it less painful and more successful. In 2018, I met with Shane, and he pitched me a way to move forward and take Ibogaine treatment to the world. The issue was to do it by getting a company public in Canada. Our goal is to get as much safety and efficacy that we can for opiate detoxification in Ibogaine. So to do that, Clear Sky Cancun and Universal Ibogaine reached an agreement, and Universal Ibogaine has the worldwide rights to license and utilize the Clear Sky protocol for operation and franchising. And we are also going to train any medical personnel that's needed in Cancun. I am the director in both Universal Ibogaine and Clear Sky Cancun, and I started working in 2004 with Dr. Mash in St. Kitts. That's where I trained to do and when I saw the first Ibogaine treatments. Then in 2005, I set up a clinic with the help of Dr. Mash and other partners, and we've been giving Ibogaine. I've been giving Ibogaine treatment since. For now, it's been more than 3,000 treatments that I have done. And one of the things that it's important is that since that time, in 2005, we know much more things about Ibogaine than we used to know. Okay, we know that it has, the issues with cardiotoxicity, and although it's the right word, I don't really like it because it sounds too obscure. I like the word that we know which kind of cardiotoxicity does Ibogaine produce. What it does is it prolongs the QT, and that QT prolongation makes the heart more susceptible to cardiac arrhythmias. This QT prolongation happens because it blocks the potassium channels, the HERG channels, and we know that there are many medications that do it, and there's a lot of things that we can do if this happens. What I show you here are monitor strips of a patient with before receiving Ibogaine, which is this one, and then the second kind of wave that goes positive here, that's the T wave. And if you see it an hour after we give the Ibogaine, the T wave is significantly flat, okay? And then 2 hours after, the T wave almost goes negative here, right? And if you see the numbers for the QT, sorry, we need to get this, is 320 when we start here, then 400, and then 520. The number for the QT, once it crosses 475, the chances of arrhythmia are higher. But there are people that live for a long time, for all their life with long QT syndrome, and they have more than 500, and nothing happens to them. So it is a problem, but it's something that it can be treated when we see it. It's not a problem. The other problem with the Ibogaine is that it's metabolized in the very specific part of the liver, and the cytochrome P450 in the 2D6 enzyme. So anything that interferes with that enzyme changes the pharmacokinetics of the ibogaine, changes the way that the ibogaine is metabolized and how it expresses to the people that take it. And it's not only medications that have influence there, but also genetics. They are fast, intermediate, and slow metabolizers. All of that is things to take care with the ibogaine. Addiction also has changed, and the opiates, since 2005. First, we just had basically heroin users, okay? They used heroin, that at that time it was heroin, and then we saw the rapid rising of oxycodone and OxyContin, up until, for several years, almost 8-10 years, I didn't have any patients that came with heroin, they just came with oxycodone. And after that, it came that they blocked the oxycodone production and people switched again to heroin. And the big changer was maybe 4 or 5 years ago when somebody decided to start lacing the heroin with fentanyl. Fentanyl, and I put this picture because that little amount of white powder is the amount of fentanyl that you need to kill a person. So it's 50 times stronger than heroin, but not only that, but by the size of the substance, you can see that try to put into 1 gram of powder so that it's equally, and that you can set it normally. So fentanyl also has the problem that it also prolongs the QT, the same as ibogaine. And we start having some cardiac arrhythmias at our center, and we knew about problems that other ibogaine providers had. So we start changing our protocol, trying to adjust it. And we reached to agreement that first and foremost, the most important part of the ibogaine treatment is the safety administration of the ibogaine. Our second most important part of what we need to do is the efficacy. It needs to be as efficient as possible and to get good results out of the ibogaine treatment. And the third thing that we also wanted to put into consideration is the psychedelic spiritual experience of the patient, which we think it is a big part of the detox through ibogaine. And after consulting with my partners and the people that have been using ibogaine for a while and know a lot about ibogaine, in Clear Sky Cancun, we decided that it was going to be an 8-day program, that we were going to give a longer switch over to a short-acting opiate for 3 days, and then that instead of a big flood dose and then small boosters, we were going to do a flood dose and then fraction dosage that saturated the ibogaine so that we can create more ibogaine down the road. But we didn't have to give a very high dosage in the beginning that is not as safe as lower dosage. During the flood dose, the patient has cardiac monitor. We check the QT, pre, post, 2 hours, 6 hours, 12 hours, and there's always the nurse and doctor in-house. And then the following fraction dose, patients are with the cardiac monitor and under observation with a doctor there too. There is not that many human studies that check on withdrawal or the effects of ibogaine detox in opiates. The original one published by Dr. Mash with 32 dependent, opiate-dependent patients, and the results were decrease OWS. OWS is objective opioid withdrawal scale, and SOWS is subjective opioid withdrawal scale. Brown and Amper, another 30 patients, and the late 14 patients in New Zealand, and then the Malcolm one with 48 patients in Mexico. In all of them, we showed a lowering of the SOWS and the OWS scale. This is the one that we found. Our group is 137 patients. They all came in for opiate detoxification, and we found that 22 females and 115 males, which is a 1-to-5 ratio, which is consistent on what we've seen in other publishers. The mean age was 36-year-old, and the country of origin, we had 118 from the United States, 13 from Canada, and 6 from the rest of the world. And even though that we are in Cancun, Mexico, we only had 1 patient coming from Mexico. And substance of abuse, 54% is heroin fentanyl. And we have to put it that way because we really don't know if it was fentanyl laced or not. Unfortunately, we could not test for fentanyl at the moment. So we had to imply that everybody that came in with heroin was fentanyl-like. And not only that, but we knew that now they're doing fentanyl pills that are masked, or they try to be oxycodone. So that's the other one. And then we had just a 4% buprenorphine and a 2% of others, hydrocodone, dilaudid, all of those ones. Of the 137 patients, we had objective opioid withdrawal scale of 134 patients. That's the objective scale that we have, and it includes yawning and goosebumps and tremor and dilated pupils. So it's something that the nurse or the medical personnel assesses. And so it is, like I said, objective, not something that the patient feels. It goes from 0 to 13. Pre-Ibogaine, we had a 2.97 in the opiate withdrawal scale, and at discharge, we had 1.36. That's a substantial decrease on the opiate scale, and it's something to be noticeable. We also ask everybody after the Ibogaine experience if they had a spiritual or psychedelic experience, and it was a yes or no question. We didn't go into the different kinds of, or what would they mean to them. It just, did we achieve that kind of experience with the dose that we were doing? That was what we were looking for. And we got a yes, 119, and a no, 15. And that's an 88% yes, which I think it's a very good number to percentage-wise for the dose that is safer and didn't get any major side effect.